Okay, so here before I begin are my disclosures, and I am really excited to talk to you all today about my favorite topic in the world. These three. No. They're cute, but I don't think that's what you're here for. So my second favorite topic in the world, which is diabetes. Specifically type 2 diabetes, although I am honored to take care of many patients who struggle with type 1 as well. So today, some of you have heard my ketogenic diet for diabetes lecture, and in the past I have gone over relevant literature. Because we're on a tighter time crunch here, I'm going to spend just a little bit of time reviewing the 2018 standard of care from the ADA, and then I want to focus on the outcomes from our large type 2 diabetes trial ongoing with Virta Health and Indiana University Health. So, I know that I am preaching to the choir here, but we've got a big problem on our hands, right? I mean, I still think, and when I say this to people who are not as educated as this group is, when we say this one simple statistic, over 50% of the adults in this country have diabetes or prediabetes. I mean, it just still always leaves people's chin on the floor. It's just an amazing statistic. And it's breaking us. So we've got to pay attention to this. Now, this 245 billion number has been around here for a while, but I actually talked to a congressional aide earlier, just about a week ago, who said, no, the newest numbers that they've run is that diabetes is now costing over 400 billion a year. I mean, whoa. And we wonder why we're in so much trouble in healthcare. I mean, think if we could just make an impact on this one disease. And again, a huge cost to Medicare. 1 in 3 Medicare dollars are spent taking care of patients with diabetes. So, and our solution has always been, every year it comes out, and this year was no different, our standard of care. And, you know, we have seen the standard of care overlay this epidemic. So we know we've got to start taking a closer look at what is actually in the standards of care, because they're put out to the public, right, as evidence-based. Evidence-based. That's how they're discussed. And the question is, are they really? And I'll give you the answer really quick. No. Okay, but let's talk about what they say anyway. So the evidence suggests that there is not an ideal percentage of calories from carbohydrates, proteins, and fat. Now this is evidence E, meaning there's not data for this. This is just expert opinion. And one of the reasons that the experts have concluded this opinion is that it's too difficult for people to change the macronutrient percentage in their diet. And what I would say to that right away is, hold the phone. We've done that, right? We did not used to eat low fat. The entire country and really the world followed, and we changed our macronutrient percent. We decreased our fat dramatically, and we increased our carbs. So that argument is empty to me, empty. We've done it, now we just need to undo it. So carbohydrates, what do they have to say? I mean, they're really frank in the standard of care. Carbohydrates will cause your blood sugar to rise. And as I always like to say, the last time I checked, the problem with type 2 diabetes is that your blood sugar is too high. So they are important. And again, going on, couple insulin administration with carbohydrate intake. And I am all in agreement with this statement. I just think I have a different approach to it than they do. Because you take any study that's got a nice graph about a 12 or 24-hour blood sugar, and you can see low carb does not couple with a lot of insulin. But a high carb intake It does, and that's important. And again, that's how we get into our vicious cycle, right? We're gonna couple the insulin administration to the carbohydrate intake, then the blood sugar goes too low, and what happens to the carbohydrate intake? It goes up. And then what happens to the insulin, right? And around and around and around we go, and these people wind up in our offices, and they're just ready to poke their eyes out. I've done everything, and every time I come into my physician's office, I'm worst. Help me. Help me get out of this. And we can all do that. All right, so this is the comedy part of the guidelines, as they continue to call the carbohydrate and insulin relationship complex. And I mean, I don't know what definition of complex they're using, but to me it's pretty simple, and all my patients get it. And I'll tell you, the area that is going to make the biggest difference here is going to be the CGM area, right? Because still taking your blood sugar, depending on how long you take it after meals, and patients may have some appreciation of it, but they got to be paying really close attention. With the CGMs, patients are going to push back against this and say, there's nothing complex about this. If I have 2 French fries and my blood sugar goes up, 50 points, I can't eat French fries. So I think this is going to be patient-driven. Proteins, they don't really say that much about it, and that's not a change from the 2016 or the 2017 guidelines. Maybe a little bit higher protein may help, but really, why is that? Because if you're eating higher protein, you're eating less carbohydrates. And fats. So it's really interesting that they call up on the Institute of Medicine's guidelines. And if you go to the Institute of Medicine's guidelines on fat, it's very specifically not for people with diseases. It's very specifically for people who are healthy. So it just doesn't make any sense to begin with. All right, so now we move in to what is probably my biggest beef here with the guidelines, is this idea that, okay, people are not capable of changing their macronutrients, even though they've already done so. So therefore, we're going to have to push these eating patterns. And we're going to focus, as we have in years past, on these 3 particular eating patterns. And we're going to give them an evidence stamp of B. And an evidence stamp of B means that there have been good prospective cohort studies done on this. But I just want to point out the huge flaw, inherent flaw right there. The idea is management. I mean, what kind of prospective cohort study is management? That's more for incidence, right? So right up this, off the bat, it doesn't really make sense. You need a clinical trial for management. All right, so let's go through their eating patterns. So in the 2018 standard of care, to support the eating pattern of MUFA, Mediterranean with an emphasis on MUFAs, they have cited 2 studies. One was on newly diagnosed type 2 diabetes and how quickly they needed medications. And, both groups needed medications and even insulin, okay? And so again, I think with a newly diagnosed type 2, this is not a good study to have included in here. I always like to say with a newly diagnosed type 2 diabetes, you can blow something in their direction and they will get better because all of a sudden they start to pay a little bit of attention. And then the other thing that they offer is an opinion piece that goes back and cites the standard of care. So we've got this circular logic going on here, right? Since there's not really any data, we're just going to continue to cite each other and then we're going to be okay. And then, of course, they always go back to the more intensive nutrition guidelines, which are only put out every 5 years. And so they're due to get redone in 2018. So I'm very excited to see if maybe we can make some headway, because the last edition of this didn't go so well. Because to find support for the Mediterranean diet, there were 6 randomized controlled trials that they looked at. 2 showed no difference between Mediterranean and standard of care. 1 looked at new diagnosis, as I talked about already. 1 did not even have glycemic control as an endpoint, so what was it doing being cited for this when this is the diabetes management section? And 1 showed that the low-carb Mediterranean actually did better. So why wasn't it in the low-carb section? Because that might make low-carb look better. We wouldn't want to do that. And 1 showed that the low carb, again, was better than either the Mediterranean or the low fat. And that's the body of evidence to recommend this as an eating pattern. Now, you think that's bad. This is worse. The DASH diet, okay? We've all heard about this. It's got some evidence in people with hypertension. But people with hypertension are very different from people with type 2 diabetes. I mean, we see overlap, okay? But the metabolic health of someone specifically with type 2 diabetes needs special attention paid to it. So what is the evidence for the DASH diet? Well, in the 2018, they cite one study that was just on healthy eating patterns. It was like an examination of a cohort study, like looking at these patterns. It wasn't on management, okay? One was an opinion piece, again, that referenced back and did our circular logic again. So the totality of evidence for the DASH diet in type 2 diabetes is one trial, 31 patients, of course, only 15 who are actually randomized to the DASH diet. That's it. That's all the evidence there is. Yet, somehow that's enough to make it a recommended eating pattern. I have a problem with that. I'm going to guess that many of you do too. And again, you go back to even the more in-depth 2013 or 2014 nutrition therapy recommendations, it cites just the one study. That's all there is. No kidding. I have searched high and low. There's not another study. So plant-based is the last recommendation. And in the 2018 standard of care, they cited two studies. One was a review of evidence supporting the Canadian Diabetes Association recommendations for a plant-based diet, which is pretty interesting because of all the studies that they used in this meta-analysis, the vast majority of them just were looking at incidence of type 2 diabetes, which again doesn't belong in the management section. And so of the studies that were looking at management, only 2 showed an improvement for a total of 27 patients. 27 patients between those 2 studies. And then there was an additional study, so it brought up the total amount of patients to close to 100. And then one was a non-systemic review, basically cherry picking some of these other studies, but it was a non-systemic review. And then we go into the more in-depth 2014 nutrition therapy recommendations. They reviewed 6 trials, and the consensus really says it all. Diets did not consistently improve glycemic control. I mean, wait a minute, right? Are we missing something? Hello. This is the recommended eating pattern to control a disease where glycemic elevation, glycemic control is our goal. And they're not helping. I don't get it. Okay, the 2014 did review low carb. And look at this. They found 11 studies. 11 studies to review. 7 clearly showed an advantage for low carb. There were 4 that did not show a difference. But if you dive into those 4, what you find is 2 of those 4 had greater med reductions. And that counts. That's improvement. That's better than the other diet, right? And one study was looking at a large group of people. Only a subset of those people had diabetes. So if you looked at the data only for the people with diabetes, low carb was way better. But for whatever reason, the review looked at the large group, diabetes and people without diabetes. And one study tried to do a low fat and a low carb, which I can't imagine what that would be like, but that doesn't work. So the 2018 standard of care did begin to discuss low-carb diets, not in their eating patterns section. And I will tell you what this is. This is this, right? Am I almost out the door, right? They're backing out, and this is the first step. At least that's my opinion. So their criticisms of low carb is there's confusion with the definition of low carb. Let's clear that up. That's not that difficult to overcome. The benefits tend to be short-term, and effects are not maintained. Wait a minute. So the effects are maintained for what you're doing? I mean, are we seeing improvement in diabetes with what we're currently doing? I mean, I think the thing is the third bullet. Ketogenic diets may be effective, but only for 3 to 4 months, as little long-term research citing benefit or harm. Okay, well, first of all, we've had longer studies come out since then, right? But the other thing is, if this is what we're going to hold up as the standards for evaluating low carb, I'm going to go back and ask, where's the long-term study on the DASH diet for people with type 2 diabetes? Because that study that had the 31 people, I can't remember off the top of my head now, it was like 8 weeks or 12 weeks or something, okay? I mean, there's no long-term data. So why? Why are we being held up to two different standards? And why are we being held up to two different standards in the midst of an epidemic that is breaking us, both with quality of life and financially? We need to do better. So, one last little thing to remember that just kind of sums up the problem here. This comes from the ADA papers. Total amount of carbohydrate eaten is the primary predictor of glycemic response. So, we'll go back to the problem with type 2 diabetes. All right, so, and we see this everywhere, right? The diabetes educators, they're pushing the exact same dietary patterns. And of course, their common thread is they're all low fat. So we can move forward from this. And again, the logic here, if the fat is low, the protein is somewhere in the middle, our carbohydrates are high. And we see this pushed in all places in the ADA. You know, you look on their websites, you're going to see they recommend 45 to 65%. You know, and I put there in the same document what they say about carbs, right? And it's just, again, seems to be an attempt to keep people sick. And we see this on their social media, you know, 45 to 60 grams of carbs a meal and more at snacks is a good starting place. Woo, okay. I mean, it just blows your mind, right? How can that possibly? Who thinks that's a good idea? All right, and then I love this quote, so I just throw this in here before we get to our trial. The discovery of insulin, good grief, it has saved so many lives, and it was such an important discovery for type 1 diabetes. But it's been used and abused in type 2. Used and abused. And oops is right. So, now I want to talk about our study, looking at things a different way. So this study is still ongoing. We're actually getting close to wrapping up the 2 years, which I'm really excited about. But we are going to extend this trial out to 5 years, so we should have some really great data along the way. So this trial enrolled almost 500 patients. 400 were intervention patients, and 100 was a control group who were just treated by the dietitians at IU through the endocrinology department. And of the 400 treatment patients, they were actually split. 200 people got their education live in the clinic, starting out pretty frequently. We met them for the first 3 months every week. And then, you know, through the 2 years, it dwindled quite a bit on how much we were seeing them. 200 got all their education online. So they didn't come to the clinic for classes, for instruction, for support, for any of that. So it was all online. And what we found when we did the data analysis was both for the 70 days and out to 1 year, there was no difference. Meaning we were able to educate people with what they needed to know exclusively out of the clinic. Meaning that they didn't have to call up and make an appointment, take the time to come in, sit in a class, listen, at a time that's inconvenient for them, and then drive home, that they could pull out their phone and take in this information whenever it was convenient for them. So it was a melding of the right science, but it was also meshing in technology. And so how did we support patients? Because that's really important, because one of the other many criticisms of low carb is that you can't sustain it. And when you do make a lifestyle change, it's hard. It was hard for people to go from higher fat to a lower fat. I mean, we did it, but when you make a change in the other direction, you're going to need some support. So all patients in the trial in the intervention were given a health coach. And they were interacting with that health coach pretty frequently, over 2 times a day early on. So it was a high-touch intervention. They were able to track their biomarkers, and by that means weight That means blood sugar. That means blood pressure for anyone who had a history of hypertension. And it also meant ketones. So they were checking serum beta-hydroxybutyrate. And they were given a physician, which in the trial was me for all of them. And that, I was adjusting medications at the beginning of the trial, dozens of times a day. Because as soon as they were putting those blood sugars in, we were reacting to them almost in real time. Okay, decrease the insulin, get this, get rid of this medication, get rid of that. And so therefore, that put in the element that is so critical here, safety, right? So our safety was impeccable. Like, we had no significant hypoglycemic events. That went really well. And then these patients were also given an online support community. So, they could get support from each other. And our primary outcomes here, body weight, metabolic syndrome criteria, type 2 diabetes status. And we have a lot of secondary outcomes that we haven't published all on, so there's a lot still to come. And so really quick, we've got 2 papers out so far on this, and that's the 10-week results that were published in 2017, and then we just released the 1 year. So just a quick recap of our early results. And the reason that I want to talk about the early results is it's really important to be getting those early results. That's part of the sustainability key, right? Having patients be able to see that change to their pharmacy bill the very next month. So the early results were pretty amazing. I mean, average reduction in just 10 weeks from 7.6 to 6.6 A1C. 87% of the patients who began the trial on insulin at 10 weeks had that either decreased or completely eliminated. 48% of those patients were able to get their A1C under the diabetes threshold. And 75% had clinically significant weight loss. 91% of them were still active. So that's good. And 20% decrease in triglycerides. So we can see, again, early results showed that your A1C improved no matter where you started from. It's always more fun. Anyone who's done this, it's more fun to get that person who just feels like there's nothing they can do and walks in your door with an A1C of 13, right? And then they come and, you see their labs in 3 months and it's 5.5. I mean, we just love that. That's fun. But it didn't matter. You improved no matter where you were. And again, medications were significantly reduced even at that 70-day mark. And, concurrent reduction in meds and improvement in A1C. So it wasn't that the people who decreased their meds didn't have as good a result with their A1C. It's actually that we saw both, right? Simultaneously improving blood sugar and reducing medication. And here's the weight loss just in that first 70 days. But now what happened at a year, right? Because of course the first criticism was everybody can do anything for 70 days. And I agree, right? It was much more important what happens further out. So at a year, where are we at? We continued to decrease. So the average A1C went from 7.6 to 6.3. And I want to point out one other interesting thing. If you remember, in the first 70 days, they had about a 7% weight loss, right? So weight loss happened about half early on, but about half of it was occurring later on, right? So if we say, well, this is only because of weight loss, we can say, wait a minute, the second half was way out here that they were losing all that weight, right? But the big change happened early. So it's not just the weight loss. All right, and what about medication reduction? We continued to reduce meds. In fact, by a year, 94% of the patients who began the trial on insulin had the insulin decreased or totally eliminated. So the medications continued to go away. And for those of you who've practiced and used a low-carb diet with patients with type 2 diabetes, it's really interesting. You get most medications off really early. And then for whatever reason, we don't quite understand what it is, but someone will just linger on insulin, for example, for a long time. But it doesn't mean that it still won't successfully be eliminated. So I will tell you that we're still eliminating medications in just a few patients, even this far out. So people are different, and we have to make sure that we have all the safeguards to keep them safe, whether we get them off of it early or if it takes them a long time. And what about the usual care, right? So here's what the usual care looked like at a year as far as medications goes. So again, we had a lot of new medications put on here, and we had virtually nothing decreased or eliminated. And what about liver function? Because that's another big one. And what we can see here is what happened between our intervention and usual care. Significant difference. And I think Steve Finney already showed this, but we had a really significant decrease in inflammatory markers, both C-reactive protein and white blood cells. And what happened with weight change? So again, it went down and it's staying down. So this is huge. This is over 12% at a year. And one of the other things to just point out is that our patients' average starting BMI was over 40. So this was not a cherry-picked crew, let me tell you. These patients were sick. Now, this is one of the most important graphs pertaining to this trial. And I'm just going to bitch here for just a minute, excuse me. But so one of the criticisms our trial had was that it wasn't a randomized controlled trial, okay? And I'm going to make a really impassioned argument why that is irrelevant here, okay? Because in the real world, people choose what they want to do, okay? You cannot package a diet into a capsule so that they don't know what they're getting. You can't hide fat, okay? They're getting it or they're not getting it. You can taste that, okay? So it's important that patients are in a real world setting. And then the second thing is in all nutrition studies, all of them, the biggest problem, the biggest limitations is that they're relying on food logs. Did the people do what you said? This is a huge limitations, and I really believe it's one of the main reasons why nutrition is such a beat 'em up, contentious field. Because nobody can ever say, I'm absolutely certain. Because we're never absolutely certain. We relied on food logs. And people lie about what they eat. And so this puts in a huge problem with all the existing literature. We didn't have the problems. We didn't rely on food logs. Our patients didn't log at all. But we know exactly what they ate because we had ketones. And how is it that solving the biggest problem that plagues nutrition research isn't better? Because I think it is. I think this is huge. So we do know that our patients were adhering. And yes, there was a drop-off over time, but even at the lowest level, they were way above what we would expect. So our patients were doing it, and they were continuing to do it even at 12 months. It's time for a paradigm change. And we can do this, and we can do better, and we can help so many people. And I'm so excited to see such a crowd here, and I have to thank Jeff and Roy for putting this fantastic program on and gathering so many people who are interested in doing the right thing. Thank you.